Welcome back to another episode of Season 3. This is Rizul, your co-host, and I'm joined today with my co-host, Nikita Yedlapali, who's a third year at FIU. And we're joined today with Dr. St Clair, who is from Wilmer Eye Institute. He's an optometrist. And I would love for Nikita to go ahead and introduce him today because I'm super excited to get started with the session.
As Rizal said, we're really excited to have Dr. St. Clair on the podcast. Dr. St. Clair is an optometrist who's interested in equalizing health disparities. He's passionate about expanding both the healthcare and social systems in the United States to be more inclusive and diverse by empowering and treating patients from all backgrounds. He has a special interest in health literacy and access to care. Dr. St. Clair graduated from The Ohio State University with a degree in Romance Languages and Linguistics. From there, he continued his education at The Ohio State University, where he received his doctorate of optometry. After graduating, Dr. St. Clair completed his residency in ocular pathology at the University of Houston. He is currently assistant professor in the Department of Ophthalmology at Wilmer Eye Institute, where he serves as the optometry residency co-director. Dr. St. Clair, we're so excited to have you, and we'll just get started with our first question. Can you tell us a little bit about your personal journey in medicine and why you chose optometry?
Yeah, so first of all, thank you so much for having me. We're a bunch of eye nerds, which are my favorite kind of people to meet. So I grew up in a small town in Alabama, and I was good at math and science. And so my mom basically was like, you should try out medicine because you'll be great for it. And then as I continued on with my high school education, she was like, you have a bedside manner for like primary healthcare because, you can like explain things to people and you like are approachable and stuff. So I kind of like looked at different primary care providers, gynecology, pediatrics, family practice. And then I realized that like in my hometown, I had one ophthalmologist and about 3 optometrists in the town, and the ophthalmologist was just like constantly in the OR. Everything from he was a comprehensive ophthalmologist. I don't think he was fellowship trained, but he did like refractive surgery, cataract surgery, like laser retinopexies, for a lot of foreign body removal, ectropion repair, et cetera, et cetera. And then if it wasn't the OR, the optometrists were handling everything else. So pediatric eye exams, low vision exams, specialty contact lenses, managing glaucoma, treating infections, eyelid lesions, that kind of stuff. So they worked really collaboratively. And when I saw like, I was like, I don't want to be in the OR. I like the primary care aspect of it. Like I really enjoy optometry. I kind of shadowed my optometrist and I was sold. It was people loved him. It was continuity of care. He wasn't like he had crazy on-call time and operations. And I just like the social aspect of it as well. So it was primary eye care, getting to know people. And then one of the things he told me, I don't know if it's the same with ophthalmology, but he was like, optometry, you can pack up in a backpack and go to a foreign country and you can do anything you need to help treat people. Ophthalmology is a little more challenging because you need like a sterile environment and like surgical equipment. But at least for optometry, he was like, you can go out and just do it and save vision. So I really like that aspect as well.
Awesome. Going into your interest in primary care, we're kind of curious, how did you get started with the free vision clinic? Because that must have been a huge undertaking.
Yeah, so I'm studying public health as well. I'm actually hopefully gonna, fingers crossed, get my degree in December of this year, my MPH at Hopkins, with a focus on healthcare policy and management because I think that's really important. Shameless plug, you can treat a handful of patients in your lifetime, or you can influence policy, which will shape hundreds or hundreds of thousands of people in a meaningful way. So I 100% am in the same camp where I believe healthcare is a human right. So kept seeing all these patients at Hopkins because it's a nonprofit hospital, and a lot of them were undocumented, or some, a lot of patients downtown are taking like public transit, the bus or the metro or whatnot. And I knew that when I was looking at testing that I needed to do to manage like acute vision loss or glaucoma or whatnot, it got really expensive really quickly. And then in Ohio, or at least near Ohio State, we have lots of free vision clinics, federally qualified healthcare centers that provide dental services, primary care, addiction medicine, et cetera. And optometry or vision is one of those offerings. And so I started looking up federally qualified healthcare centers in the Baltimore area that provide vision services, and there's not one that exists. There's plenty of FQHCs or CHCs, community health clinics, but there's not one that provides any vision services. So I kind of was like, I approached my master's advisor and I approached our faculty and I was like, listen, I want to create one. And we need a space to do it. And so they were like, great, partner with whoever you can think of. So I reached out to a bunch of people. And then I really have a soft spot in my heart for immigrants and refugees, because no, that's a whole another conversation. Like like America dealing with like language barriers, cultural differences, our healthcare system, even if you're an English speaker, it's like a dumpster fire. So I was like, I can't imagine being like a Syrian refugee or an Afghani refugee coming here, not speaking English well, and having to navigate with your 4 children, something as simple as like my kids can't see to be able to participate in school, kind of a thing. So that was really important to me. So I found this one group called CASA, and CASA said, listen, we have this space. We're an immigrant refugee center, but you can do whatever you want to with it. And I said, great. So then I called up the Maryland Optometric Association and I said, listen, a lot of docs are retiring. If any doc is retiring, I will take their equipment. And then I just started taking my admin time. I traveled to different parts of Maryland picking up equipment. And then I turned a storage closet into an exam room. So it was really fantastic. A lot of the stuff's dated, but it's completely functional. And I host these clinics, every like 2 or 3 months or so. I try to do at least once a quarter. And we have anywhere from 40 to 80 patients who sign up for eye exams. So it was really beneficial. But I saw there was just a critical need. And I just hated having to charge people so much when there's preventative medicine in society nowadays, which Hopkins, or I guess Baltimore just hadn't tapped into yet.
Yeah,
yeah, go
ahead. Sorry, Nikita. I actually wanted to ask you a follow-up question on that. You've started this clinic. Are the equipment like loaners, or do you get to keep them for your purpose of the clinic?
Great question. They're all donations, so they're all mine. Technically they're CASA's. So when docs retired, they're like, here, I have an eye care, take it. I just had a guy contact me about 2 weeks ago. And he said, hey, I said, I need an autorefractor because we have all these patients. A lot of them, like I speak Spanish, but a lot of other people don't. And so they're doing retinoscopy on people, and they might have, extremely dense cataract. They may have a corneal ectasia or dystrophy, and we don't get good reflex. So it's really challenging to do retinoscopy. So I told them, like, we need an autorefractor, and it would save us a lot of time. And a guy just all of a sudden messaged me and goes, hey, I'm based out of California. I heard about your clinic. I have an autorefractor. I'll pay for shipping and handling. You just let me know where to go, and I'll take a tax deductible, whatever. And I said, done. So we have an autorefractor now. So I get to keep them, which is good. But we're always accepting donations because we love more updated clinic. Our clinic is very 1975, but we're slowly building and updating the stuff.
So how do you get the word out that, I'm accepting these equipments? And I feel like most of these retiring docs they might be tech savvy, they might not be. I mean, we're talking about surgeons, so they have to be tech savvy, but
Right.
Not in the sense of social media.
So I think a great way to get involved there is to talk to your local like ophthalmology association. I don't know if you have like a group. So every state has an optometric association, and it's basically there for you to network, build in referrals, commiserate about like, hey, listen, I don't know how to code and bill for this, or how are you guys implementing this new healthcare policy in your office? And so I really use that, and so I joined the Facebook group. And I said, hey, listen, I'm collecting this equipment. So I feel like it'd be a very similar thing if you were to launch your own clinic wherever you're going. Hey, I'm going overseas or I'm doing a whatever. And I wouldn't try and reinvent the wheel. There are probably organizations already in place where you could make that happen. But if you want to start your own, if you're in a Gainesville, Florida or whatever, and there's nothing around, just be like, hey, listen, the Florida Ophthalmology Association or whoever you want to reach out to, I'm looking to start a clinic, and what kind of donations do you have? If if there's no one in your area, there will be other people that will reach out because I'm tech savvy, or I'm like social media savvy, so I was not about to let that be an obstacle for me to get my equipment.
Awesome.
That's your question? Okay.
I also have a question about the equipment. Do you guys have equipment for like dilated fundus exams? Is that something you do?
You got it. So the whole purpose was this was not supposed to be a screening methodology. We wanted everyone who walked in that door to be like, I got a complete eye exam. So we have like tropicamide, phenylephrine, proparacaine. We have gonio lenses in case someone has a narrow angle. We check gonioscopy. We don't have any fundus cameras, but we have auto-refraction eye care, a full slit lamp, a phoropter. I mean, and everyone there is obviously trained, and we take. So the answer is yes. It's all full complete eye exams with medical grade everything. The only challenges we have is that I use a Snellen 10-foot chart, which is frustrating because the room's not big enough to do a 20/20 with mirrors and everything. I can't build into the room. And I can't shuffle or randomize the letters. So if someone's savvy enough to learn them or memorize them while they're waiting, then it doesn't get a good it doesn't give a good exam, but everything else is fine. And most of the times we haven't had any complaints. We've seen a couple patients for follow-up. They came back for the second day of community. Oh, my glasses are working great, and they're seeing 20/20. They just wanted to stop in because they're receiving other services from CASA, so which is good.
Yeah, that's so amazing that you do like the full eye exam. And it's kind of crazy to see that there was no vision care in the entire like Baltimore area. Um,
Right.
so with that, with considering that, like what are some of the most common vision problems you see in the community that you're serving right now?
Great question. I mean, refractive error is obviously a big one. People don't know what they don't know. So I'd say the most common like pathologies would be amblyopia. People have no idea that they have a bad eye. So strabismic amblyopia, deprivation, refractive amblyopia, those are all extremely common. Keratoconus is really common. A lot of our immigrants, refugees are from, especially in like the Middle East and some parts of Africa. So keratoconus is obviously more prevalent in that. And so they're like, oh yeah, well, I've always had a bad eye, and they don't realize obviously it's both eyes affected. Diabetic retinopathy, not so much. Glaucoma, very common. And then probably refractive error. It's very uncommon. You'll have some like retinal lesion. I have seen a couple like nevi and chirpies that I've seen in the peripheral retina. But it's for follow-up care, we send tons of patients for cataracts, and that's why I want to make sure I partnered with Hopkins, because I wanted to say, listen, we will send these patients who don't have insurance to the resident clinic, and we have a service called the Angel Care Fund that allows patients who are in between like insurance ability to have free cataract surgery as one, as a teaching opportunity, and two, to help with donors who are willing to engage or pay at least part of that. So cataract surgeries are our main referrals. Strabismus surgery occasionally, glaucoma, like if they come in and their eye pressure is like 42 or something like that, and they have an open angle, I could start them on drops, but we know that they're not going to be on drop compliance if it's been X many years for them to come back. So I send them for the glaucoma division for them to maybe put in a shunt or do a laser or something like that. But yeah, cataract's the main one, amblyopia, and glaucoma.
Awesome. I was just wondering, you're talking so passionately about the clinic, and it almost seems like the clinic started without a hiccup, but I am sure that that is far from the truth. So what challenges did you face when you were establishing this clinic? And already I'm starting to think, what are the financial issues and the staffing issues? Because we already have staffing issues in a regular clinic. So I can't imagine how it is like for a free clinic where you're serving, almost a full clinic day worth of
Right.
patients.
It is a free clinic. It is a full clinic day. And I do get that the burnout is, I think, real, because I have to remember like there's going to be a lot of education, a lot of hand holding, and I'm just one person. I would say the collecting things was not the hardest part, because people were just, once they find out they like a cause, they're willing to go out of their way and give that to you. I'd say the hardest part was, and we're still working on this, is sustainability. Like we meet people like us, we're very active and engaged, and we're like, listen, we want to change the world, we know we can make it happen, but there's just me, there's just one person. I told them, like, I could get a job offering tomorrow, making this up, at University of Colorado, and they're going to make me the chief of the whatever division, and I can go, and right now, my clinic doesn't have the legs to stand on to be sustainable. All the equipment's there, people are aware of it, but I'm the one driving like all right, we're having another day. I need volunteers. I need at least like 10 volunteers. I need at least 2 runners. I mean, I'm the one organizing that. So I think the biggest challenge right now is sustainability. If you can get buy-in from different groups, nonprofits, or if you're working with somebody, like I went to school for eyes. I'm really good at eyes and I know public health and I don't know billing and I don't know, how to set up insurance systems and how to register as a federally qualified healthcare center. I don't know that. So I think just making sure that you reach out and find the right people to make it sustainable. Otherwise it's just like I did a mission trip overseas. And although that's great,
Right.
ideally you would have like an optometry school in parts of India or Ghana or whatever that are able to train somebody to the expression like teach somebody to fish versus giving them a fish. You would ideally want to, teach somebody how to fish so they don't have to be so reliant on you.
Yeah, I 100% agree with that. And, as you're explaining how you're this one person and we're talking about sustainability, I'm sure there are medical students dying to be a part of this service organization. In some ways, how do you incorporate someone who is really early on in their ophthalmology training, or hasn't even started in this case? And how do you try to implement their efforts into supporting and making this clinic sustainable?
That's a great question because I do have a couple of pre-optometry students. I do get pre-med students who come in, but they usually want to do or more focused on doing research publication. But for the pre-optometry ones that I have from Hopkins and University of Maryland, I'd say same thing I tell the medical students, shadow first to make sure this is what you are interested in doing. And then once you're shadowing, I ask my students who are in my clinic, they're like, hey, I'm like, you can take notes and kind of like sit back while I'm doing an exam. Or if you want to get involved, you're more than welcome to. I'll sit down while you're asking the patient questions like check for acuities. I'll teach them how to do eye care. I'll teach them how to do just basic lensometry, autorefraction, that kind of stuff. Like those are very simple things that are clinically relevant. And so then once they've done that and I've gotten them used to doing that, I'll say, hey, listen, I'm hosting this clinic day next month. You're welcome to go, spend as much or as little time as you'd like. And then they get to see it in action. And it's not going to be an easy flow of a hospital. You have patients who have language barriers, who are maybe illiterate, or maybe, don't have the accessibility of medical knowledge to understand the gravitas of what's going on. You have a lot of
Mm-hmm.
that. And so I'm like, yeah, listen, like your pressure is extremely high. This looks like a basal cell carcinoma. This looks like we have to follow up with that. And they're like, well, just give me lotion for it. I just need glasses for that. And I'm like, it doesn't work that way. So it's I think once you can volunteer, if you can find an organization where you can actually, hopefully the doctor you're shadowing is teaching you some of the skills or letting you learn some of the skills, then I think it's a great way to get involved in the profession, and be useful. And also it saves you time in the long run, right? So when you matriculate into ophthalmology, you're not like, well, I've never used a lensometer before. I've never, checked color vision or, stereopsis. You're able to bring that to the table.
That is a very good point. And I feel like there's, what caught me by surprise on an earlier statement you made was how these FHQs clinics don't actually have an eye clinic component. This is a pretty important topic to discuss. Like,
Yeah.
why do we not have the eye component involved? Ears are something you can quickly check if somebody isn't hearing well, but eyes is something you have to, there's different layers of the eye that you have to check. And it speaks volumes as to like why do we not have that? What are your thoughts on why we don't have this inclusion?
I'm honestly not sure. I thought it was at first I thought it was required that any federally qualified healthcare center had to have everything. I've quickly learned that's not the case. You can have an FQHC that just has primary care and like pediatrics, or primary care and addiction medicine only, or primary care and dental only. I think it's mainly like, again, advocacy, which is what you guys are doing. It's like I have patients who come in and they'll say, "Oh, I went to this FQHC," and I'm like, "Yeah, you're treating the addiction medicine. You're doing like maybe the drug testing or whatever, the diabetic checks. You're getting your medication from the pharmacist." But I'm like, but at the end of the day, if you can't see to go to class, you can't see to drive a vehicle, if you can't see to, you know, cross the street or whatever, I mean, what's it all been for? Or if you have something silent that will take away your vision, like glaucoma or a retinal tear or a if you have all these
Mhm.
things that are just waiting to rob you of that independence, or at least cause some major hiccups along the way, that's doing you a disservice. And so I always tell people, whenever you pull them, the vision is the most important the most important what do you call them, sense, that
Mhm.
hands down, whenever you ask somebody what would they rather have. So I don't know why it's not prioritized more. It really made me sad, which is why I'm glad I launched the clinic, because we really did need it. And I'm hoping that everyone, hopefully who hears this, will look up what federally qualified healthcare centers do or do not have vision services, because that's a real, again, disservice not to include those. I mean, most people aren't looking up FQHCs, but have you looked up some in your areas to see if they have vision services?
No, they do not. And it's, when you brought it up, I was like, yeah, you're right. I never thought it of like that. And maybe part of it is how vision is treated separately from regular health. And that's where the problem really stems from. A dentist could argue the same because they're in the same lump as, as the same pile as vision. Um, and so, both of these are equally as important, and yet we don't work in a team to incorporate all these three elements.
That's actually where my health policy is coming into. Funny you said that. I frequently will talk with people. I get my little tangents, and I'll say, "Yeah, I'm trying to reform the healthcare system." And they go, "What do you mean?" And I go, "Something as simple as people say, oh, I have Medicare,' and I'm like, "Okay, that's great." And they go, "And I just need glasses today," and I'm like, "First of all, they won't cover glasses." And
Mm-hmm.
unless you have an eye problem, they don't cover routine vision services. Now you can come in saying I have decreased vision, or I have double vision, or I'm a diabetic, I like to get a diabetic eye exam, and then they'll cover it. But it's plain Jane routine, what the layperson says, they don't know that that's not covered. And it's like, who decided in the grand scheme of things? Yeah, we'll cover everything, but like this and this, like those are two arbitrary parts of the body they're not covering, which makes no sense. But I'm hopefully going to, and hopefully you'll help me out in getting vision services covered for patients, because they really do need it.
Yeah, the biggest issue right now is the Medicaid expansion. And right
Yep.
now, as the changes are being made, patients are not able to use their Medicaid accordingly, and they have to wait for a certain period before they become eligible. And it's a constant infighting with certain states. How much do they cover? Why is it not uniform? And it's just a bit of a chaotic mess.
Yeah, I agree. And also, like, the formularies and prescription drug coverage, I'll have a patient that I'm starting on medication, and I'm like, listen, you need to be on this one. And they'll go, oh, my insurance doesn't cover that. And I'll go, okay, we'll cover this one. Oh, my insurance doesn't cover that. It'll cover the one that came out, 25 years ago. And I'm like, that is wasting your time. We know it's not going to be as efficacious. And it's like, I hate the barriers there. So there's so many things that need to be changed with the system. But that's definitely one of them. That's an access to care issue for sure.
Yeah.
Yeah, definitely. And that also brings up like a point about referrals once you do see the patient. So like what is it like referring the patients who are have this background with like Medicaid and Medicare? How do you get them the care that they need?
Great question. So the ones so a lot of the people don't even know that they qualify for insurance. So if it's an open clinic, even that says for immigrants and refugees, it's an open clinic, anyone can attend. So if someone comes in, we had a couple people who are homeless. If they come in and they're like, listen, I'm homeless, or I'm struggling with housing, with security, then we have social workers at CASA who go, listen, here's a program we can set you up with. We can get you Medicaid, we can get you these services, and they help them out. If they're truly like undocumented, we have again nonprofits there to help them work through the legalization process. If they have Medicare and Medicaid, if they have some sort of whatever, and they just are like, we'll say, hey, listen, you went to this CASA clinic, but you could also go to Hopkins Hospital or any other hospital, and here are the ones that we give them a list of, these are all the ones you can go to. Obviously, I work at Hopkins, and we're affiliated with Hopkins for the public health school, so that's where I like to refer people. And then I tell people, you can go anywhere. You can see me again if you want to go to Hopkins, or if you need surgery, then I'd rather them go to the surgery clinic. Or if they're on a fixed income, then I send them to the resident clinic. Because again, our residents, part of the residency program is to allow them to do reduced cost visits for the sakes of education. So instead of doing, I don't know if you're familiar with the different technology, but if you're like, if I need like a B scan and a corneal topography and a fundus photo and a whatever, in my clinic, that would rack up a bill of maybe like $800 to $1,000 for a full exam, versus in the resident clinic, they'll say, nope, that was a teaching opportunity or that was a didactic learning, whatever. And so at least cuts the cost to some degree. And so I like to refer them to the resident clinic if at all possible. The residents get that exposure, and then the patient gets continuity of care with another provider, with Hopkins at least.
Okay, yeah, that's good that they have that system in place because not everyone has a chance to go see the ophthalmologist and get that further care. In Miami, we do have like a referral system. If you're screened at any of these like local fairs, there's a referral system that can get you into seeing someone who's in private practice as well. Is
Oh,
that
nice.
something that exists in Baltimore, or is it mainly like in partnerships with academic centers?
It's mainly academic centers. And I think it's because private practices, I'm sure, would offer to do that. But again, I am personally against uh privatizing healthcare. I think that when you dangle a carrot of making money off of somebody for for things that they can't control, sometimes that can be weaponized and taken advantage of. I'll leave it there. So for sure it works in the academic medical centers. And again, I can only speak for Hopkins because all of our patients are able to continue care at Hopkins if they want, but we do give them a sheet and say you can take this anywhere. I know some people, for the sake of cost, have been like, well, I want to go to like a Lens Crafters or whatever. And again, even though, Lens Crafters is a big corporate chain, it's access to care. Like someone who's just wandering in for eyeglasses goes in, they find, oh, you have a detached retina, you have like an amelanotic nevus and you need like an evaluation. So they will say, hey, listen, like everything looks fine, but make sure you're going to an eye care provider every year to check for like diabetes. And they might choose to go to like a Lens Crafters for that. So yeah, I can't speak for private practice vouchers, at least for Baltimore.
Yeah, so just going off of that, another question we just had is do you work with any ophthalmologists at the clinic, and do you see any gaps that they could fill potentially?
So again, the answer is absolutely. The ophthalmologists I have currently, I think they're pre-ophthalmology, they're international ophthalmology residents from obviously other countries, and they're waiting to do I think their match here in the United States. They're in that lay period. I'm not using the right terminology at all, but you understand what I'm talking about. So some are from like Jordan or Syria or whatever, Mexico, and so they're waiting to get back into ophthalmology here in the US. I think there is an overlap that we need for with surgeons. I would love to involve more surgeons. This is just kind of comprehensive, again, like routine preventive medicine, which is why I think optometry is kind of well fit for that because like optometrists aren't trained to do cataract surgery. We're not trained to do a retinal detachment surgery or like a strabismus surgery. So there's a limit to what we do. And so I think this is helping streamline, again, getting the surgery cases to the surgeons who are really good with that. But again, a lot of these international ophthalmology residents or prospective residents are just really excited just because they're looking for the same thing. They wish that this would have happened in like their hometown or their home country. And so I think they're just happy to be involved. So if I tell people, if you can work a slit lamp and you can assess, there's plenty of room for more doctors. So yeah, collaboration is key. I think that's also why optometry and ophthalmology work so well together. It's that coordinated care. I have a lot of I think it's a lot of surgeons I work with are like, listen, if it's like sudden loss of vision, eye pain, whatever, I want to do surgery, like I'm a board certified, let's say like corneal surgeon or glaucoma surgeon, like I need to do surgery. If it's a whatever and you can handle it, keep me doing what my clinical skill set is. And so I think that that's a great collaboration that most eye care providers nowadays take full advantage of is the collaborative efforts.
Yeah, and I think this is pretty important because we kind of box, certain specialties with certain areas or for certain type of patients, but we don't realize that with ophthalmology, in places where optometrists aren't able to be as prevalent, and vice versa. You kind of need to work in conjunction with each other. And there's a lot of primary care involved in ophthalmology in areas where, a lot of the care is lacking. And in that respect, you kind of have to wonder, what do you do to facilitate that and make everything more efficient? Because in your clinic, you're the person who is taking care of people, and it's kind of like you are referring them out to the ophthalmologist. You do
Right.
have that resource. At the same time, you have this supply of pre-residency folks who have already done, education for ophthalmology elsewhere. So you are technically working with ophthalmologists
Right.
who are providing that primary care. So it's a little bit interesting to see that dynamic in play.
I think they also want to be a part of the surgical aspect. Like if they see a really good case, they're like, I wonder if I can scrub it with Dr. So-and-so and like follow up on that retinal, whatever. That so we had a couple patients just for like pterygium repair, like pterygium removal, and then I had a couple we had one patient who had keratoconus. I think they were trying to do a cross-linking laser procedure with him. So those international ophthalmology students were like, I need to follow up with this guy to make sure that like I'm there so I can do continuity of care. So he has a similar face at the follow-up visits. So you're 100% correct. That's definitely needed for the collaboration.
Yeah, that actually sounds pretty cool that they're able to, follow up on these patients.
Yeah.
So, what advice would you have for others in a similar situation who are inspired by having to listen to this podcast and they also want to start up their own free clinic? What are some things that you would recommend that they do, and what are some things that you recommend that they don't do?
Great question. So I would say the first thing I would want to do is make sure there's a need in your area. There probably is a need in your area. Find people to buy into it. So that's the main thing. I was like, I can't host out of my own house, but if I find a group that's willing to let me start this and get buy-in from them, then that's worth it. So if you find a local organization, it can be a community organization, a nonprofit, whatever. But even the local optometrist or ophthalmology clinic, if you say, hey, listen, I want to run a free whatever out of here one Saturday a month or like every other month for a Saturday, that's the next thing. And then getting coordinating equipment like to be in the room if you find yourself volunteer donations or whatnot. I would say try not to work independently because you put yourself at liability risk. And then make sure that the patient preference is always available. So even though I tell people like, hey, listen, I did a full eye exam for you today, I would love for you to see me back. Literally, I'm just glad someone took a look at your eyes today. You can say you had a full eye exam. I'm giving you a paper copy of your exam with our assessment and plan written out. This is your copy. You can take it wherever you want to. Here's a paper copy of your glasses prescription. You can take this wherever you want to. And I make sure that the patient knows that they're not siloed to only seeing me. And then if they're like, hey, listen, I had one patient came in who goes, yeah, I went to go to like, let's say a Lens Crafters and America's Best last year, but I want to make sure I saw like someone real this year. And I'm like, well, we're both doing the same thing. We're both looking at the back of the eye. I mean, you have nothing going on. There's no pathology that I'm seeing. So if you have a good rapport with that doctor, I'm not going to steal them away from you. Go back and see them. Like there's plenty of patients to be seen. But if you want to join me, again, I'm happy to have you. And I that's why I try and make sure I'm not taking anyone away. It's all patient care. You choose what's best for you. I'm just offering you the options, if that makes sense.
Yeah, I'm glad you brought up liability because starting an initiative like this, you always want to be concerned about that. Who is somebody that you could ask to cover for liability insurance? How does that work with such an endeavor?
So the good news is if you're just screening and you have you should, so I don't think you're allowed to do screenings without a licensed professional with you. So if you're doing a screening and you're like, listen, I can't find an ophthalmologist who will do the screening with me, there are plenty of optometrists. I don't know I think there's like 15,000 optometrists nationwide or 18,000, something like that. You can definitely find optometrists who will sign off on a screening. That's not a big deal. But if you find ophthalmologists, again, totally fine. You just have to make sure you're not a non licensed individual telling somebody, nope, no glaucoma in your eye, or like you don't need glasses, and they have something major going on. So and then just make sure you're comprehensive. Like I would try and avoid just being like, well, I checked your eye pressure, I checked your acuity. Because that's like two very small aspects of what eye health is. So if you're gonna go for a screening, I would go for like a real screening. Check posterior pole. They use a direct ophthalmoscope if you can. Check eye pressures, angles, pupils, eye muscles, confrontations. Do at least the bare minimum of what like a screener would involve. The more you can do, the better. But that's also, I was like, well, I'm already halfway there. I might as well just dilate them, take a look in the back, which is why I end up converting mine to full exams, especially because I had 10 doctors who were willing to volunteer with me to make it happen. So just again, find buy-in, cover yourself legally by finding an eye care provider who can sign off on stuff.
Yeah, good point.
Yeah, that's amazing that you provide all that services, and those are really important things to keep in mind. So I hope everyone listening, takes that into account as well. And so, running this clinic, I'm sure you come across people from all walks of life. Do you have like a memorable story or a patient interaction that really stood out to you and that's special to you?
So the answer is yes. There are, I mean, one of the biggest ones was I had a kid who came in who was like 10 or 11 or so, and his mom was like, didn't know much about the family history, which is like, oh, his dad's blind. And I was like, oh, okay, his dad's blind, whatever. And then we couldn't get his acuities at all. Like his acuities were horrible. That was like, but the technician or one of the students who was volunteering to be a tech couldn't get any acuities. And then we brought him back to the phoropter to try and do retinoscopy. And one of the optometry resident was like, I think this guy has keratoconus because I'm getting a huge scissoring reflex. The reflex is really unstable. And then when we put him over into the slit lamp, we could already see he had apical scarring. He was like 10 or 11. So he had a very advanced form of keratoconus at a very young age. And that was one of those things where it's like, whatever it was, I don't think he was picked up on his elementary school nurses screening. His mom just happened to hear about the clinic and brought him in, and he most likely got cross-linking and probably a referral for a specialty fit keratoconic contact lens to maximize his vision, because obviously if it's already scarring at age 10 or 11 years, it's the chance of him having a corneal perforation or having some major need for a surgery later down if we don't do anything is highly likely. So that was kind of like a wow, we really saved vision today. Yeah, and then again, the common ones were glaucoma, where it's like, wow, like this definitely looks like glaucoma. And they're like, well, I'm feeling fine. And you're like, okay, well, glaucoma really doesn't progress with like a visual issue unless you're really far along in the course. So explaining that aspect of like, just because you can see well across the street does not mean you have no eye issues going on, which is again preventive medicine. So that the patient with keratoconus and always the glaucoma stories are major.
That's amazing. Yeah. I think it's like interactions like these and, personal stories like this that really stick with us and inspire us to keep moving forward and, push us every day to do what we do. So that's amazing. And just as our concluding question, looking ahead, what are some like goals and aspirations you have for your clinic, and what are your plans to keep it thriving in terms of financially and staffing and everything considered?
So I think the goal currently is to make it sustainable, and that's what I've kind of talked to like the board of directors at CASA and stuff about. I said, listen, we need grant funding. You need to at least be able to afford to pay like an optometrist to be in here once a month. So that's like the goal is to have it be completely sustainable within the next couple of years. I mean, I'm not leaving Baltimore anytime soon, so I can always help out. But that's the main thing. And then I would love to have the clinic be part of converting CASA into like an FQHC, or at least getting it part of a community health clinic atmosphere. So incorporating other primary healthcare professions in, I think that'd be great. Those are kind of my current clinic endeavors. Speaking internationally, I'm working on a coalition right now to help provide eye care in Sierra Leone. I mean, internationally speaking, there is a huge need for eye care providers. And so my current passion project, I'm sorry, I have a pug, he's snoring. So I have my current passion project is to get accessible eye care to some very remote areas. And a place like Sierra Leone, the statistics are they have 6 ophthalmologists and 4 optometrists for a population of 8 million people. So 92% of the blindness in Sierra Leone is preventable and 64% is treatable. So, I mean, I don't know if India is near and dear to your heart, but even places, like Pakistan or like Bangladesh, if there's any kind of no eye services in that area, just collaborating internationally to make sure we can create preventative healthcare measurements to prevent blindness. That's always important. That's always important.
Awesome. So Dr. St. Clair, it's been a pleasure learning from you. I think you've included so many valuable insights about starting a service clinic, and not only that, but highlighting the lack of eye care in the normal setting of a medical free clinic. It has kind of helped us understand where eye care stands and what we need to, do further to make it better. Any lasting words, Nikita? I've thoroughly enjoyed those.
Yeah, thank you so much. I think this has shed a lot of light on the problems that we're facing right now. I mean, I know for a fact that, there's all these free clinics around Miami at least, but only a handful of them have care with optometry. And so that's really interesting to think about how we can get that policy push forward. I was going to ask, actually, do you have any advice on how we can get involved with those policy changes as medical students?
I'm sure, great question again. I'm sure that there's probably medical service organizations that lobby, like at the state day, or if you're involved in public health, there's always healthcare initiatives taking place. And so when you have those rally on Capitol Hill or talk with your legislators about whatever, just saying, hey, listen, I represent whatever, and this organization. And did you know that there's currently no vision services as a part of this plan, or under the current whatever, only one eye care or only eye exam every like 7 years or 6 years is covered, and that needs to be increased to more. So just doing your part on the political level to get engaged with looking up, I guess, like legislative efforts, and when your organization has like a state day to rally, make sure you're fighting for access to eye care for your patients. That's really, really, really beneficial.
All right. Well, thank you, and happy World Sight Day, everyone.
Yeah, likewise. Thanks so much for the invitation.
Thank you.